Welcome to our recall session of yesterday's NEET-PG 2022 paper. We will be discussing the OBS and gynae part of it. I am Dr. Reena Chawla. I have my own classes by the name of OBG classes by Dr. Reena. You can find me on Instagram and on YouTube. I am also senior faculty with DocuMe. So if you want to listen to more interesting lectures like this, you can subscribe to our channel. So let's quickly do a brief analysis of the NEET-PG yesterday's exam. So as usual, the past year also we've had lots and lots of OBG questions. Even the recent NICT also lots of OBG questions. So that basically implies that OBG is a very important subject. Let me just get my pen in order. Just a second. Yeah. Okay. So OBG is a very important topic, and many of you find it tricky, many of you find it difficult. But this time the exam, the level of difficulty was actually moderate with a lot of easy questions also, but majority of them were moderate. They definitely were some tricky ones, a lot of distractors which were tricky. Okay, so yes, all in all it wasn't, I wouldn't say it was a very easy paper with respect to OBS and gynae. It was moderate. Okay, very similar to last year's paper. But the topics from where the topics where the questions came from were all expected topics. A lot of questions from ectopic pregnancy or contraception and pre-eclampsia, eclampsia. These are expected topics. Okay, there's a list Mullerian anomalies which came in last NEET-PG also, so that was again expected this time. So lots and lots of high yield topics, lots and lots of clinical scenarios, and this was throughout the paper. The entire paper had, I think, more than 50% were clinical scenarios, and around 60% were actually images. There were lots and lots of images. A lot of them were irrelevant because actually the question didn't require the image. But yeah, in OBS and gynae, I think there were 6 images, but overall there were 70 plus images in the entire paper. So images and clinical scenarios now form the basis of most of the questions, and that's what has become important for NEET-PG exams. And remember that the clinical scenarios, although take a little more time, but they're actually quite simple. Once you get the gist of it, they're actually quite simple to do. And images, of course, you need to practice lots and lots of images to get to understand them. And again, so there were previous year questions were there. Many of you may feel they weren't. They were actually, but more of them were quite indirect. They were less of direct, repeat, exact recalls. But yeah, so from the same topic, like last year, there was a NEET-PG question on, there was an image-based question on unicornuate uterus. This year, the same HSG picture, but a different Mullerian anomaly. So that's how it was a little different. But if you revise previous year questions, you know your high yield topics, and you can answer most questions related to that topic then. Okay, so let's now quickly start. So let's start with a few image-based questions. Identify the type of hymen. Okay. Now, is this a septate, semilunar, annular, or cribriform? And the correct answer is a septate. You can actually clearly see, I think in the actual exam, it was a little asymmetrical, okay? But it was, septa was definitely there in the middle. Okay, this doesn't have much of clinical importance, okay? I don't know why it was asked, but yeah, so this could, you can even say this was from anatomy, but these are the different types of hymen. This is an annular hymen, a ring shaped. This is a cribriform hymen. This is a septate hymen, what came in the exam. So different types of hymen, okay, and this is very straightforward, nothing much to this, okay. Next question, which is a contraindication to this, okay. So this is, what is this? This is a intrauterine device, a copper containing intrauterine device. Which device is exactly? Is it? It's the multi-load 375. Okay. So basically they're asking you what is a contraindication to a copper containing intrauterine device. Is it menstruation? Is it trophoblastic disease? Is it condom rupture during intercourse? Or is it following delivery? So let's start from backwards. Following delivery, yes. Okay, what is called as post-placental IUCD insertion, which is encouraged a lot these days. Within 10 minutes of delivery of the placenta, we insert this. So yes, following delivery, yes, even after 48 hours, we can insert the copper T. Condom rupture during intercourse would become then, the woman would come looking for emergency contraception, and a copper containing IUCD is actually a very good option for emergency contraception. Up till 120 hours or 5 days, we can insert the intrauterine device following such a problem. Okay. So emergency contraception, yes, it can be used. Trophoblastic disease, no, it is an absolute contraindication, and that is why this is the correct answer. Menstruation, so yes, we don't really put it during the period, we don't really insert it during the period, we do it to call the patient after she's done with her period, then we insert it. But if you see amongst all the options, this is not a absolute contraindication. Okay, it's not even a relative contraindication. It can be put, it's just uncomfortable for the patient. The chances of expulsion are higher. The correct answer is trophoblastic disease. What are the other absolute contraindications to copper-containing intrauterine devices? Pregnancy, of course. Unexplained vaginal bleeding. She's bleeding, you don't know the cause. Gestational trophoblastic disease, as we just discussed. Then all the 3 genital cancers: cervical cancer, endometrial cancer, ovarian cancer, and the presence of an infection, a sexually transmitted infection, or pelvic inflammatory disease. These are all absolute contraindications to copper-containing iodine. Remember, contraception is a very, very important topic. It's a very high-yield topic. Always a question on contraception is expected because it's a very important topic. Otherwise, when it comes to Government of India guidelines and as a country, India, contraception is a much required thing. That's why it becomes important. Okay, next question. Following delivery, the placenta is being removed by traction on the structure shown. So what structure is this? This is the cord. So traction is being put on the cord. So this is basically controlled cord traction is being done in the 3rd stage of labor. This is how we deliver the placenta. The structure snaps. So what happened? The cord snaps now. And that is profuse bleeding. What is the next step in management? So once the cord snaps, it becomes difficult to get a hold on the placenta. It becomes difficult to deliver the placenta otherwise. But we have to remove the placenta. So what do we do next? Okay, oxytocin. So oxytocin would have already been given. If you remember active management of 3rd stage of labor, the first thing we do is we give oxytocin 10 minutes IM or IV. Otherwise also you may think she's bleeding, so you want to give her oxytocin. But remember, by giving oxytocin, you will be closing the internal os also. You won't be able to deliver the placenta. So the first thing we need to do is deliver the placenta and then start your oxytocin. Okay, uterine massage won't help in any way till the placenta is out. Arranged blood and Creed's method. Arranged blood, yes, obviously you will do because she's bleeding profusely. But what is Creed's method? Creed's method is an obsolete method. It's basically removal of placenta without taking these precautions. It's just sort of pushing on the fundus of the uterus and pulling the cord out. So this suprapubic pressure is not given, and this would lead to a lot of uterine inversions. So it is not done anymore. Remember this. So the correct answer is manual removal of placenta. Next question. A 59-year-old woman presents with anogenital warts. Genotyping of the virus is done and it shows her to be at risk for atypia or squamous cell carcinoma. What is the likely genotype? So it's basically asking you high risk HPV is which of these is high risk, and this was also a straightforward answer. We know HPV 16, 18 are the most common high risk types, and this was the correct answer. The rest are all low risk. Okay, so remember what? So HPV is again a question which comes in every paper, be it INI, be it NEET-PG. It repeatedly comes because it's sort of a very important area again, especially when it comes to cervical cancer. So these are the high risk types. Okay, 16, 18, as I said, is the most common cause of cervical cancer, apart from the other ones, 31, 33, 35, 39, all those. Okay, these are probable high risk and these are low risk. Okay, so remember 6 and 11 are low risk and they are the ones which generally cause these warts. Okay, so benign low grade abnormalities in the cervix or laryngeal papillomas or cutaneous or genital warts are caused by 6 and 11. Okay, but infection of the high risk types are what we're worried about, and these can cause cancer. Okay, and what cancers can they cause? They can cause cervical cancer, anal cancer, oropharyngeal cancer, vaginal cancer, and penile cancer. So this is what you need to know. Of course, there's so much more about HPV, but we won't go into too much details. Okay, but this is important from what came. Next question. So we're just finishing the image-based ones, I think, in the beginning, then we'll move on. So identify the plain colored green. So identify this is a maternal pelvis, and they basically asked what is this plane. So this plane is the plane. Is it the plane of the outlet? So where is the outlet? This is the outlet. Okay, so you see this pelvis, this is the outlet. So it's not the outlet. It's neither the anatomical outlet nor the obstetrical outlet. Is it the inlet? Okay, where do you think the inlet will be? This would be the inlet. Is it the inlet? No, it's not the inlet. So what is the correct answer? This was a very easy question. It was a plane of mid-cavity. Normally you would expect difficult questions on pelvis and skull. This is one of the easiest questions which came. Okay, and this is the plane of the mid-cavity. Now let's just understand a bit more. So this is a similar, this is the inlet. You can see this plane is the inlet. This one and this one. Okay, these are both the mid cavity. This is the plane of the greatest dimension. That is the biggest space in the pelvis. And this is the plane of the least dimension. That is the smallest space in the pelvis. And this is the outlet. Okay, so if you see this diagram, this is easily the mid cavity. Now the plane of the inlet, to go into a bit more detail, what you find anteriorly, you find the superior margin, posterior superior margin of the pubic symphysis, and what you find posteriorly, you will find the promontory, sacral promontory, and the ala of the sacrum on the sides, and on the margins you'll find the laterally you'll find the iliopectineal lines. That is the border of the inlet, plane of inlet. What is the border of the mid cavity? You have the plane of greatest dimension. Again, you have anteriorly the pubic symphysis here. Okay, laterally you have the upper and middle thirds of the obturator foramen. Here's the obturator foramen, you can see it here. Okay, and posteriorly you have S2, S3. Okay, so remember, plane of greatest dimension is at the level of S2, S3. Plane of least dimension is the level of S4, S5. And remember, plane of least dimension is at the level of the ischial spines. Remember where the head gets stuck most often. We have a question on DTA also. So this is the plane of least dimension. This is where most obstructions happen. This is where most arrests happen. They can ask you in the next exam, which is the plane where most arrests or most DTAs happen, or where arrest of descent happens. This is at the plane of the least dimension. Why? Because it has least area. So that's why the head gets stuck there. And what is the plane of outlet? So plane of outlet, anteriorly we have the subpubic angle here. Okay, posteriorly we have, if we're taking the anatomical plane, we have the coccyx, the tip of the coccyx. But if we're taking the obstetrical plane, we have, so when the head is pushing here down, the sacrococcygeal joint is mobile. It will move the sacrococcygeal joint piece posteriorly, and this would be the plane. So this is the obstetrical outlet. So it's either here, this is the anatomical outlet, this is the obstetrical outlet, the actual outlet through which the fetus passes. Okay, and of course on the lateral parts you have the bituberous diameter or the ischial tuberosities on either side. So these are the planes. Okay, and pelvis and skull is a very important area from which questions do repeatedly come from. Okay, so now moving on to the next question. A 35-year-old man. So this is actually a question from pathology, but a lot of questions came which were integrated. So I just tried to pick out the relevant obs and gynae questions and go take it from there. So a 35-year-old man who is undergoing evaluation for infertility, semen analysis shows azoospermia. Okay, so what was done next? A testicular biopsy was done and this image was seen. What is the diagnosis? Is it a germ cell tumor? Is it a Sertoli only cell tumor? Is it a testicular atrophy, or is it orchitis? Now the most confusion was between these two. Okay, is it Sertoli only cell syndrome or is it testicular atrophy? And the correct answer, this is Sertoli only cell syndrome. Okay, so in an only Sertoli cell syndrome, which is seen here, so we don't see germ cells. Okay, germ cells are absent. We don't see spermatozoa. Okay, and this lining of only Sertoli cells here around here is called a wind-swept appearance. There are absent germ cells and there is very low or absent spermatogenesis. And these patients are typically normal on examination, and diagnosis is made on the testicular biopsy findings. So there's absence of germ cells, which is characteristic. And this picture here, the Sertoli cells arranged like this is called a wind-swept appearance. This is testicular atrophy. Okay, so testicular atrophy will have this thickening of the basement membrane. Okay, so thickening of the basement membranes will be seen. Okay, there'll be a lot of fibrosis in between. Again, spermatozoa will not be seen, but germ cells will be seen. Okay, so this is a little difficult question, I guess, a little tricky. Okay, but this is, now that you should know this is how Sertoli cell only syndrome looks like. Okay, again a tricky question. Okay, I'll call it tricky because many of you are getting confused with this. It's actually not very tricky if you come to think about it. A 28-year-old woman who delivered 18 months back and is breastfeeding. So she delivered 1.5 years back. Okay, and she seeks contraceptive advice. Now the next question holds the clue. Her periods are irregular and heavy. They're irregular and they're heavy. So the best contraceptive for her would be what? Okay, would it be what is progestasert? It is a progesterone containing intrauterine device, like Mirena, right? What is NEET-PG? It is a monthly progesterone. So it's a progesterone injection. So it contains norethindrone enanthiate. That's why it's called NEET-PG. What is Mala-N? We all know this is a combined OC pill. And what is copper T380A? It is basically the 10-year IUCD, which is recommended by the government of India. Now see what she has. She has two issues. Number one, she's breastfeeding. Number two, she is having irregular and heavy periods. Now, is this breastfeeding significant? Okay, her baby is 1.5 years old. So, what is the recommendation for combined OC pills in breastfeeding? The recommendation is it can be given, but only after breastfeeding has been established. So, it's usually contraindicated in the first 6 months only. After that, once breastfeeding is established, it does not affect the quantity or quality of breast milk. Only when the woman is trying to establish breastfeeding, and that's why it is not given in the first 6 months. But after that, breastfed women can be given, women who are breastfeeding can be given combined oral contraceptive periods, and that will also solve her issue of her irregular and heavy bleeding. Her periods will become regular and the bleeding will become less. Because if you give progesterone, what will happen? Her irregular periods will persist, okay? And if you give NETN, the same thing, her irregular periods will persist. You're not helping her in any way. And with copper T, her heavy bleeding will increase. Okay. So this A, B and D will not solve her problem. Combined OC pills is the answer because breastfeeding, so this is there to trick you. Okay. Remember that. So less than 6 months woman, you cannot give combined OC pills. If she's delivery has been more than 6 months, yes, you can give combined OC pills. Remember this. All right. So it's not a blank absolute contraindication. So always remember when you're reading contraception, go through the WHO MEC criteria. Okay, which says if it's category 1, you can safely give whatever contraceptive there is. If it is category 2, you can give, but the benefits outweigh the risks. 3 is the risks outweigh the benefits, and 4 is you can't give. It's absolute contraindication. So for easy, so if it's 1 or 2, you can give. And if it's 3 or 4, you basically can't give. Okay, in simpler words. So if you see breastfeeding and combined oral contraceptives, after 6 months, they come under category 2. So that means you can give combined oral contraceptives in women who are breastfeeding. Okay, next question. Okay, so this also is a nice interesting question. I think most of you got this right. A 22-year-old primigravida is overdue by 2 weeks. She visits the OPD with complaints of vaginal bleeding and abdominal pain on the right side. On examination, her vitals are stable. Abdominal examination is unremarkable. A bimanual examination reveals a bulky soft uterus with no tenderness and no adnexal mass. Okay. Mild bleeding is seen. Beta HCG is 1400. An ultrasound reveals a trilaminar endometrium and both the adnexa are normal. So what is the next best step? So here we have a young primigravida who's come with bleeding and pain. Okay. Bleeding and pain, but she's quite stable, and on examination you find nothing of particular significance, but you find her beta HCG is 1400, okay, and the ultrasound is normal. Nothing is seen on the ultrasound. So when you have a UPT positive, that means the beta HCG is there, but nothing is seen on the scan. Okay, what is that called? It is called as pregnancy of undetermined location. So she is pregnant, but we don't know what it is. We don't know where it is. Okay, it could be a failing intrauterine pregnancy, it could be a failing ectopic pregnancy, it could be a growing ectopic pregnancy. We really don't know. So we have to investigate further. And how do we do that? We do that by repeating a serum beta HCG after 48 hours. Because what will happen if we repeat a beta HCG after 48 hours? If it is an intrauterine growing pregnancy, it should increase by more than 60%. That is what is called as doubling time. Okay, doubling is a misnomer. The increase should be more than 60%. So if I do a beta HCG, her beta HCG is 1400, and if it's a growing intrauterine pregnancy after 48 hours, the beta HCG should now be more than 60%. It should be at least 3000 and above. Okay, then we know yes, it is an intrauterine growing pregnancy. Okay. Also, there's something called the discriminatory zone. That is at a value of 1500 beta HCG, serum beta HCG, we should be able to see an intrauterine sac on the TVS. And at a value of around 6000, we should be able to see an intrauterine sac on an abdominal scan. Okay, so it's 1400. That's why probably we're not seeing anything. So it could be a completely normal pregnancy. It could be an ectopic pregnancy. It could be threatened abortion. It could be complete abortion. It could be a failing intrauterine pregnancy. It could be anything. Okay, but how do we know? So what do we do in the management of pregnancy of undetermined location? The first thing we do is we repeat a serum beta HCG after 48 hours. So a patient comes with positive UPT plus pain plus bleeding. What do? If she's stable, she could be stable or unstable. If she's unstable, we obviously, it's ectopic pregnancy, we offer surgical management. If she's stable, we do a transvaginal scan to see where the pregnancy is or what is the cause of bleeding. So it could be an intrauterine pregnancy. Okay, it could be an ectopic pregnancy. So you may see an ectopic pregnancy in the scan, you may see an intrauterine pregnancy. In both cases, you are sorted. You know what to do now next, right? The problem comes when we don't see anything. So it is non-diagnostic or a pregnancy of undetermined location, and herein lies the role of serum beta HCG at 0 hours and at 48 hours. So this is why this is a very important algorithm. It's a very important topic. It's come in the past also. It's expected to come in the future. So understand the concept of pregnancy of undetermined location. We know she's pregnant. We just don't know where the pregnancy is. It might be very early. It might be an ectopic. So how do we do? What do we do next? We do a serum beta HCG and we repeat it after 48 hours. Next question. This is also a little weird question, and I don't really know what the examiner was getting at with this. A patient at 22 weeks presents with profuse vaginal bleeding. Her BP and sugars were normal. Again, I don't know why this point was mentioned. The likely site of implantation is it ovarian, tubal, at the internal os, or abdominal? Now, please remember, ovarian and tubal will never reach 22 weeks. They will rupture much before. Okay. So usually they rupture by maximum 8 to 10 weeks. So it's very impossible, next to impossible for them to reach so high. Abdominal can reach. Okay. In fact, abdominal pregnancies have even been reported to go till term. But they won't present with profuse vaginal bleeding. She may have a little bit of spotting because of shedding residua, but the placenta is implanted outside in the abdomen. Okay, it's seeking its vasculature, blood supply from other organs. So there's no way abdominal pregnancy usually bleeds. Okay, so this is also out. Internal os, so I think here what they were trying to say is a low-lying placenta. That means a placenta implanted in the lower segment, what will eventually present as placenta previa after the period of viability. So placenta implanted in the near the internal os or low-lying placenta is typically how such a patient would present. So that's why this should be the correct answer. Okay, next question. Again, nice big clinical scenario given, and then they ask a very simple question. Okay, so a 39-year-old gravida 2 para 1 presents at 18 weeks 5 days for her routine targeted fetal anomaly scan. The fetal anatomy appears normal, but the cervical length is 15 millimeter. Okay, so the cervical length is less. Despite being counseled that there is no clear proven benefit for the same, the patient insisted on a cervical cerclage. Which of the following is a complete contraindication to cerclage? So they're basically saying which of the following is completely contraindicated to cerclage. Okay, is it a positive fetal fibronectin? Is it membranes bulging into the vagina? Is it ruptured membranes or is it advanced vaginal age? She's 39 years old. The correct answer is you will never ever put a cerclage if the membranes are ruptured. It is only put when the membranes are intact. In all the other conditions, you can do. Membranes bulging into the vagina is technically difficult to do. Okay, because if you reduce the membranes with a sponge on a sponge holder, a gauze on a sponge holder, we gently reduce the membranes and then take the stitch. And usually it tends to tear through because the cervix is now dilated. But it still can be done. It's called an emergency cerclage. Okay, the rest are also indicated. So what are the absolute contraindications to cerclage? It is chorioamnionitis, ruptured membranes, current bleeding. If she's bleeding, you can't put a stitch. If she's getting active contractions, if she's more than 4 centimeter dilated, you're just going to be cutting through the cervix can't close. Okay, and if the baby is not alive, obviously there's no point doing a cerclage. Okay, again, easy question. G3P2L2 7 weeks for termination of pregnancy by medical methods. What is CAC guidelines? Comprehensive Abortion Care Guidelines. What do we use? So, the Government of India has said you have to use Mifi. So, Mifi was there in all the choices. Mifi is RU486. It is an anti-progestin. Okay, and with this, we give misoprostol. So this is the correct answer. What is misoprostol? It is prostaglandin E1. So remember, anti-progestin mifepristone is given for 200 milligram orally, followed 48 hours later by 600 microgram of PGE1 or misoprostol. Okay, next question. 34-year-old primary with jaundice and a BP of 140 by 90. So her blood pressure was raised. Her investigation, see, her serum bill is slightly raised, SGOT is raised, SGPT is raised. Normally the normal value is 40. Anything more than 72 becomes significant. Her LDH is raised. Normal LDH is still 600. So LDH of 700 is raised. And her platelet count is less. Okay, also remember her KFT and coagulation were normal, and this is important because it helps us rule out one of the conditions here. Okay, so what is this? It's very, very clear. Blood pressure high, hemolysis is there. So whenever LDH is raised because when red cells are destroyed, they release LDH. So hemolysis, in the presence of hemolysis, LDH will be raised. So we have hemolysis, we have elevated liver enzymes, and we have low platelet count. So this is classic HELP syndrome. Why is it not AFLP? Because her coagulation is normal, her KFT is normal. Okay, although AFLP does present at this gestation, it does present many times with hypertension, but in AFLP, her bilirubin would have been much higher, her liver enzyme would have been much higher. Okay, of the order of 500 to 1000. In viral hepatitis, the liver enzymes would be in thousands. Okay, that's why it's not viral hepatitis. Okay, bilirubin also would have been much, much higher. Okay, and intrahepatic cholecystitis of pregnancy, it is not there because SGOT, SGPT, yes, are raised, but none of the other features would be seen in this. What would have been seen would have been a bile acid. A serum bile acid raised would have been seen in this case. Okay, next question. A 34-year-old G2P1 presents at 35 weeks. She has no complaints and is appreciating fetal movements well. She had a previous classical cesarean. So remember this. Okay, so many of you missed this point. Classical cesarean at 25 weeks for eclampsia and severe growth restriction. She is currently on low dose aspirin and prenatal vitamins. On examination, the uterus, the symphysiofundal height is 38 centimeter. Fetal heart is okay. The ultrasound reveals a fetus in breech, placenta posterior, amniotic fluid normal. The patient desires a vaginal delivery. What is the best management? Okay, so now see the only clinching thing, such a long case scenario, it goes on about everything. You would think breech is important, but what is most important is the previous classical cesarean. Okay, whenever you have a patient the previous classical, whatever else it be, you will deliver her by a repeat cesarean section. Please remember this, the chance of rupture is very, very high, up to 4 to 9% if you allow her to deliver vaginally. So even after 2 weeks, if you do a scan and has turned to cephalic, it doesn't matter. I still won't give her a trial of labor after cesarean section. I will still schedule an elective LSCS at 37 weeks because of the previous classical section. If she was previous LSCS and this baby turns to cephalic, maybe I would have given a trial of labor, but not now. Okay, the others are out of the question. ECV not done because of the previous classical section. Await spontaneous labor, obviously internal validation, of course you won't do this. And review scan after 2 weeks. Why not? I'm saying because it doesn't matter if the baby turns now. Okay, you will do a repeat LSCS. Primey at 40 weeks, she has been in labor for 3 hours. Which of the following will determine she's in active labor? What is active labor? Okay, we all know active labor now by the new WHO definition is more than 5 centimeter. And this question has come because the new labor care guide, which is the next generation partograph, says the onset of active labor is after 5 centimeters. In my high yield topic discussion, I had mentioned this, that labor care guide is very important. It can come, and that's why this is the correct answer. Okay, so contractions will be there, of course, for the cervix to dilate. Head, this is irrelevant. This is irrelevant. The only way to diagnose active labor is a dilatation of more than 5 centimeter. It used to be 4 centimeter. ACOG says more than 6 centimeter. So Williams gives more than 6 centimeter. The WHO says 5 centimeter, and this has been used for the purpose of the labor care guide, which is the next generation partograph. Expect questions from this topic now onwards. Okay. A multi is in the second stage of labor since 2 hours with good uterine contractions. On examination, the head is 1/5 palpable. Again, this was a tricky question. Okay, and I'll tell you why it was tricky. So, a multigravida, remember this point? Okay, on examination, the head is 1/5 palpable. Fetal heart is good. On vaginal examination, the cervix is fully dilated. The head is at the ischial spines in ROT position. Caput is ++. Molding is ++. How will you deliver her? Okay, so first of all, what is this? This is deep transverse arrest. Alright, what is deep transverse arrest? It is basically when the head is stuck in the transverse position, that is the sagittal which is in the transverse plane, okay, and for more than an hour with good uterine, despite good uterine contractions, the cervix the patient, the further descent is not happening, because what happens in DTA, internal rotation is not happening. Why is it not happening? Because either there is CPD, or it happens very commonly in grand multis where the levator ani is very lax. Okay, and hence for internal rotation to happen, there should be something pushing from above and resistance from below. So when that happens, internal rotation happens. So here the baby is getting stuck either because there is CPD or because there is a weak levator ani. Okay, and that is the definition of DTA. So more than 1 hour, head stuck in transverse position despite good uterine contractions, despite full dilatation. Okay, nothing further is happening. So what will you do? Okay, now here please remember, okay, if it was a primigravida or if there are features of obstruction, the answer should be emergency LSCS. Okay, and why am I a bit confused with this question? So this question was a bit confusing to me also, and I'll tell you why. Because if it was a primigravida, I would have definitely marked emergency LSCS. But here we've given a question where it's a multigravida, and apart from 2 plus caput and 2 plus molding, which is not exactly pathognomonic of obstruction. Okay, again, if it was obstruction, the answer would be emergency LS. So in the event of a primi or in the event of obstructed labor, you will do an emergency LSCS. But if it is a multigravida, we know her pelvis has been tested, she's delivered before. The cause just may be a weak levator ani. In that case, we can either do a vacuum, or if very experienced, you can use a high rotational forceps. So it is called as Keylands forceps. So mid cavity is wrong, because for mid cavity rotation needs to be complete. Oh wait, one more hour is wrong, because otherwise you will end up in trouble. She's already been in labor for 2 hours. That is the upper limit for a multi. Vacuum is where now I am a little confused. Okay, so this question for me is controversial, mainly because it is a multigravida. The cause could be a weak levator ani, and a vacuum delivery can be done in DTA in the case of multigravida. Okay, so vacuum has the property of causing rotation. Okay, so rotation is not a problem. Okay, and the pelvis is anyway adequate. Okay, but if you consider caput plus plus and molding plus plus as signs of obstruction, then the answer is emergency LSCS. So I would go with 60-40. 60% emergency LSCS, 40% vacuum, and I'm still trying to find out more references for this question. I discussed with many obstetricians, many senior faculty in medical colleges, and it's sort of a little confusing, this question. Okay, so it's either emergency LSCS or vacuum, but more in favor of cesarean, because caput plus plus and molding plus plus. What is deep transverse arrest? Good uterine contractions, head at 0 station, such items within the transverse diameter for more than 1 hour if there is no progress. So all these should be fitting to call it as DTA. What do you do if it is a primi, or if there are features of obstruction? Directly cesarean. But if she's a multi, okay, you can, apart from a cesarean, you can also try a vacuum or rotational forceps. Okay, so I hope this is a little clear, although I need to look up more references for this question. Next question, easy question. Collapse in a patient during labor or delivery followed by bleeding and DINC in the absence of coexisting conditions is most likely due to, okay, and the answer is amniotic fluid embolism. So sudden postpartum collapse in a woman who's otherwise all right, and usually this happens after ARM or starting oxytocin, okay, and happens during labor or in the second stage of labor. Once the baby's just come out, patient suddenly goes into cardiovascular collapse. Okay, this is because amniotic fluid enters the circulation, and that causes amniotic fluid embolism. Postpartum hemorrhage, no. And otherwise, so she's collapsed and then she bleeds. No. So in PPH, she'll first bleed and then she'll collapse because of the hemorrhagic shock. Eclampsia, no. There are no seizures. Peripartum cardiomyopathy does not present like this. Usually, it presents after delivery, within a month of delivery, the patient will not have sudden cardiovascular collapse. She will have symptoms before she goes into cardiac failure. Okay. What is AFE? It is a serious intrapartum complication caused by amniotic fluid entering the circulation in cases of hypotension, shock, and collapse. It has a very high mortality, and it happens in low-risk patients. If it happens, it gives a very big shock to both the doctor and the patient. So it's very sad, but yes, it does happen. And risk factors, as I said, following an ARM, following oxytocin, multiple pregnancies, it is seen more common in this group. Suspected diagnosis, it's always a suspected diagnosis. It is always confirmed on autopsy when you find presence of fetal squamous cells in the maternal pulmonary circulation. And the management is resuscitation, oxygenation, and correction of coagulopathy. Right. Next question. A 22-year-old type 1 diabetic is in the post-operative ward following a cesarean done for failed induction. So she had a cesarean for failed induction. The indication for induction was pre-eclampsia with severe features. So she was basically a patient of severe pre-eclampsia who underwent induction and then had a cesarean for failed induction. She is also type 1 diabetic. She now complains of drowsiness and altered sensorium. So she's in the post-op period complaining of drowsiness, altered sensorium. She's on maintenance magnesium sulfate infusion. So she is probably presuming that she was started on prophylactic Maxalt to prevent eclampsia. And now she's on the maintenance infusion, which is usually given at 1 gram per hour. Okay, according to the Zuspan regime, and on IV infusion of insulin. Now what happens on examination? Her pulse is 70. So pulse is okay. BP is slightly high. Respiratory rate is 10, so that's less. Auscultation of the lungs reveals bilateral normal air entry. Abdominal examination reveals a firm uterus with normal tenderness. Phalangeal scar is intact and there is no significant vaginal bleeding. So operatively doesn't look like there's a problem, right? Bilateral patellar reflexes are absent. And why were reflexes checked? Because whenever a patient is on magnesium sulfate, we check three things while she's on the infusion or while she's on the maintenance dose. We check for respiratory rate, we check for the patellar reflex, and we check for the urine output. A urine dipstick for protein and sugar is negative. And I think also output mentioned here was given. Output was less in this question. And a capillary glucose sample is 270 mg/cent. What is the suspected diagnosis? Is it magnesium toxicity? So two things that come to your mind are these two. Because she's severe preeclampsia and she's on magnesium sulfate, the second thing you think of is diabetic ketoacidosis. These are anyway out. And this answer was magnesium toxicity because very classical presentation. What happens? The reflexes initially go absent, then respiratory depression happens, and then the patient becomes comatose. Neurological effects happen. So what should we do? We should immediately stop the magnesium because clinical magnesium toxicity is there. So how will you manage? Next time the question can come on management. What should you do? You should stop the magnesium, send magnesium levels, okay? Send serum magnesium to monitor the levels. And what is the antidote? Give her calcium gluconate. Okay, so this is the treatment. This is how you will treat this patient. Okay, next question. Which of the following will you see long bone fractures in the fetus on antenatal scan? Will you see it in Marfan's osteogenesis imperfecta, achondroplasia, or platonism? And the answer is OI, osteogenesis imperfecta. And when I saw this question, when I got to know this question had come, I was very happy. And why? Because those of you who are fond readers, if you've read this book by Jodie Picoult, Handle with Care, and she's a brilliant author, you should read her books. Okay, so this book was about a little girl. Okay, I've forgotten her name. I think her name was I've forgotten her name. Okay, so she was born with osteogenesis imperfecta, and this girl's mother sued her obstetrician friend who delivered her basically because she felt she had missed the diagnosis on the antenatal ultrasound. Okay, and the doctor was actually her best friend. So it's a very emotional book. And I read this many years back, but just reading this question immediately reminded me of this, and I had to put it here for those who are interested. Now you're on your break. Those who are avid readers, please pick up this book. It's a brilliant read. Okay. Spectrum of so what is osteogenesis imperfecta? So it is a spectrum of defects characterized by fragile bones, and it's their type 1 to type 8. And I think most of you, this is not an obs and gynae topic, but I'm just telling you. So type 1 is the mildest form, type 2 is the most severe. And what do you see on the antenatal ultrasound? You see fractures of long bones or other bones also, but characteristic. This is the femur, you can see a fracture. This is the humerus, you can see a fracture. And also there is hypomineralization of the skull. So the dense white skull which you see will now not be dense white. Okay, I didn't get a good picture, so I didn't post it here. Okay, it will be slightly less white than what is normally seen. So hypomineralization of the fetal skull. So these two, hypomineralization of the fetal skull and fractures of long bones, are what is seen. When you read this book, you will immediately you will understand. It is all about antenatal diagnosis of osteogenesis imperfecta. Nice question this was. Okay, next question. A G2P1L1 presents at 28 weeks. On examination, the uterus is 24 weeks. On ultrasound, there is absent liquor. Which could be the most likely cause? Okay, so this again is a relatively straightforward question. It's a previous year question. Okay, so what happens when there is absent liquor in the second trimester? Think of renal anomalies, because after all, what is liquor? Liquor is urine. The baby which passes urine, that is the main source of amniotic fluid. So think of renal anomalies when amniotic fluid is absent in the mid trimester. What can this lead to? This can lead to Potter's facies, okay, where you have a flattened nose, facial defects, limb defects. So that's because there's no space, and when the baby comes out, it'll have pulmonary hypoplasia. Okay, so this is the correct answer. Congenital heart disease usually, if at all, may be associated with polyhydramnios if the baby goes into heart failure. TEF, definitely polyhydramnios. Hydrocephalus, again, there is no real relation unless there are other anomalies. So the answer for this is fetal renal anomalies. This was an easy question. Okay, so this is where I was saying last year, what came last year? I think unicornuate uterus came in NEET-PG, HSG picture. And this year, what has come? So remember, HSG is not a good modality actually to differentiate between septate and bicornuate. This is obviously not unicornuate. It is obviously not didelphys, because there's one cervix seen. Okay, so it's either septate or bicornuate, and on HSG is not a good modality. The best modality is to do a 3D ultrasound or an MRI. Okay, but this is what we were given. So given, and this was, I think this is a similar picture to what was given, but what I heard was that the angle was less than 70 degrees. This angle between the two cornea, if it was less than 70 degree, the answer should be a septate uterus. If it is more than 100 degrees, the answer should be a bicornuate. Now you can figure out yourself what the angle was, but from what most of the information I've gathered, it was a septate uterus. Okay, so that should be the answer, but I've explained to you what you should look for in the HSG. So let's quickly just see. So in bicornuate uterus, the HSG demonstrates separate fusiform uterine horns and the intercorneal angle is more than 105, right? Like here, you can see the angle here is obtuse. Okay, and this one is a ignore this. This is the spill of the dye. This is the uterus. Okay, here you can see here. So here the angle is less than 70. Okay, so it's mostly a septate uterus. So V-shaped configuration. So right, whenever you see a V, that is a septate. Okay, whenever you see something like this, it is a bicornuate. Okay, so this is another way you can remember. But as I said, the best way is a 3D scan. Okay, here I put a picture of didelphys, and this was the last NEET-PG, unicornuate uterus. Okay, but the best way to see this, these are 3D ultrasounds. So what you do in a 3D ultrasound, you draw a line between the two endometrial cavities. You see these two white things, this is the endometrial cavity. So you join them by drawing a line, okay, like here, and then you join a line at the top, the fundal contour. You join a line here and you measure the distance between the fundal contour and the top of the endometrial cavities. If this distance is less than 2 mm or it's crossing through, it is a bicornuate uterus. But if this distance is more, then it is a septate uterus. So this is another way on 3D scan how you can differentiate between, and this is obviously the best way. And of course, confirmatory, if someone asks how will you confirm the diagnosis, it is always by a laparohistro, by a diagnostic laparoscopy. Hysteroscopy is the confirmatory diagnosis. Okay, the investigation of choice for a Mullerian anomaly is a 3D ultrasound. So HSG is actually very poor. The sensitivity of HSG in differentiating bicornuate and unicornuate bicornuate septate is actually only about 50%. So this question should not have been there, but since it's come, if it's V, it's a septate. If it's something like this, it's a bicornuate. Next question. Okay, 34-year-old woman is advised an ultrasound Doppler and a double marker between 11 to 14 weeks. Doppler of the umbilical artery helps predict what? Late onset pre-eclampsia, early onset pre-eclampsia, FGR or placenta preta. And the answer here is early onset. So remember, when we talk about prediction of pre-eclampsia, we have several things. It is done mainly between 11 to 14 weeks, and importantly, very important, the medical history. Is she chronically hypertensive? Is she a primigravida? Does she have family history? Does she have APLA or SLE? Okay. Does she have a previous history of pre-eclampsia? These are all medical history-wise risk factors. Then the uterine artery pulsatility index, if it is raised, that means there is more resistance in the uterine artery. So it's not a good thing. And if you have biochemical markers, that is like placental growth factor, PAP-A, there are many others, and this came in the last INI. Okay, so combination of all three, there are softwares which calculate the risk calculation, and this risk is for early onset pre-eclampsia. Okay. So what they give you is the risk of early onset pre-eclampsia. If she's low risk, continue with routine care. But if she's high risk, then start low dose aspirin. They say 75 to 150 milligram before 16 weeks. It has to be started before 16 weeks to prevent eclampsia. Okay, especially severe preeclampsia from happening, because this is when the second wave of trophoblastic invasion will happen. This is how a uterine artery PI looks like, uterine artery Doppler looks like. Okay, there's another question in the paper on Doppler, I think some other subject. So you should know how Dopplers look like. I think many of you would have got it because you know how umbilical artery Dopplers look like, you know how uterine artery Dopplers look like. So this is a Doppler. Okay, next question. So this is actually in continuation of the previous question. That's why I put them together. And pre-eclampsia, eclampsia is such an important topic. See, 3 questions directly in this paper from this topic. 34-year-old woman develops pre-eclampsia at 28 weeks. She's very anxious and asks, why has this developed? Many women do this. They come to us, the doctor, and say, why did I have to get this? Okay, so you explain to her that there's a problem in the development of maternal fetal circulation in early pregnancy. What is the cause for this? Okay, now here again, there was a confusion between two. Okay, there were 2 choices of spiral arterioles. These were out. So there is basically poor extravillous trophoblastic invasion or deficient second wave of extravillous. So this word is important, extravillous trophoblastic invasion. And let me explain this. So these are the syncytial trophoblastic cells outside and the cytotrophoblastic cells inside. And these are the anchoring villi. Remember the picture of the placenta? You have a lot of anchoring villi. And this picture is from Williams. Okay, so again, I will repeat, Williams is your standard book. Okay, and even in the INI, a lot of questions directly picked up word to word, line to line from Williams. This diagram also, what does it say? The cytotrophoblastic cells are, some of them enter the placental bed, and these are called as extravillous trophoblasts, and they go and what do? They replace the endothelial lining of the vessels and cause them to expand, to nicely expand. Okay, and if they don't do that, so this is normal. If they don't do that, the spiral arterioles remain thick, they remain constricted, they remain with less vascularity, and that is what leads to pre-eclampsia. Okay, so remember this word, extravillous trophoblasts. Okay, again, this is a previous year question. Okay, what was asked, I think 2-3 years back, was in the first trimester. Okay, but here the question was a little twisted, and they could have made it much simpler. They made it a little confusing. A primie at 12 weeks. So she's come at 12 weeks and she wants to know the additional daily calorie requirement she would need to take. Is it 300 kilocalories throughout pregnancy? Is it 400 kilocalories in the second trimester or in the third trimester, or 200 in the second trimester? So remember 0. Okay, I've gotten the next slide. Okay, so 0, around 350 and 450. So this is your correct answers. No additional calorie requirements in the first trimester, 350 in the second trimester, and 450 in the third trimester. So with that, if you see, this becomes our best option. Okay, this also, many of you have marked this because yes, 350 kilocalories is what ICMR recommends throughout pregnancy. Okay, but if you see Williams, it says in the first trimester, no additional calorie requirement is required. If we go by Williams, this is our more appropriate correct answer. Okay, so what does Williams say? Williams says that the Institute of Medicine 2006 recommends no extra calories in the first, 340 in the second, 450 in the third. And what does ICMR say? 350 kilocalories in throughout pregnancy. It's not mentioned trimester wise. Okay, so this is why this is a better answer in my opinion. Okay. Okay, again, easy question. On the second postnatal day, where will the fundus of the uterus be? Will it be 1 finger below the umbilicus, 2 finger, 3 finger, or 4 finger? And the correct answer is 2 finger. Why? Because immediately after delivery, where is the uterus? It is just at the level of the umbilicus. From the first day onwards, it starts reducing in size or involuting at the rate of 1 finger breadth per day. Okay, so 1 finger breadth per day is how it reduces. So on postpartum day 2, it will be around 2 finger breadth below the umbilicus, and by 10 days to 2 weeks it becomes a pelvic, it's no longer palpable, it's a complete pelvic organ. Okay, next question. 28. So there were, I think, 28 questions in all. We're almost at the end, but that's a huge number for obs and gynae. And obs and gynae is a very scoring topic. So remember this. A 28-year-old woman is on her third postnatal day. A psychiatric consultation is sought in view of occasional crying episodes, fatigue, and lack of sleep. What is the likely diagnosis? So here the clinching thing is third day and she has mild symptoms. Okay, so this is classically puerperal blues. Okay, many women, in fact up to 70% of women will have puerperal blues. Okay, 5 to 10% will have puerperal depression. Okay, so the answer was puerperal blues. So what is puerperal blues? It is 70 to 80%. Postpartum depression is around 10%, and postpartum psychosis is quite rare. Okay, so it usually presents, the classical third day was given, it presents 2 to 4 days postpartum. Okay, this can present up to a year postpartum also. Okay, so the average duration, it usually resolves in 10 days. If it's persisting beyond 2 weeks, that is when you start thinking of postpartum depression. And this is what you'll see. You'll see little mild symptoms here. Here the symptoms will be more severe, and of course here it's completely different. Okay, and here nothing needs to be done. Just a bit of counseling to the mother. Give her a bit of tender, loving care, and she will be all right. Okay, next question. A woman, this is actually a PSM question, but I put it here because it also comes under obs and gynae. A woman living in an urban area in MP delivered at an institution or on counseling by an ASHA worker in 2018. What monetary benefit would she and the ASHA worker be entitled to under the Janani Suraksha Yojana scheme? The JSY scheme basically encourages women to deliver at institutes, and who helps the woman reach there or counsels them is the ASHA worker, and for that she gets an incentive. Okay, now the GSY scheme has been divided into basically low performing states and high performing states. So high performing states is Madhya Pradesh is a high performing state. Low performing states are the 10 states like Bihar, UP, Uttarakhand, those areas, okay, and a few others. But MP is a high performing state. And this is from the GSY document of 2009. Okay, and what there they said was, again, urban area and rural area. So she is saying in an urban area, the mother will get 600 rupees and the ASHA worker will get 200 rupees. Okay, but here they've revised the incentive for the ASHA worker in 2018, and this is from that document. Okay, what they've said is the incentive is now 400. So for a woman staying in an urban area in a high performing state, the woman will get 600, the ASHA worker will get 400, and that's the correct answer. Okay, so this is something you have to learn. It can get asked. I'm sure it's come in the past. It comes more from PSM, but yes, it had an obs and gynae component to it, so I put it here. Which hormone stimulates the male fetus to produce testosterone? Okay, and here the answer is HCG from the placenta. So Leydig cell differentiation and proliferation depends on placental HCG in the first and second trimesters of fetal life, and on fetal pituitary LH thereafter. So HCG actually has a LH is similar to LH, and that is why it leads to testosterone production in the male fetus. Okay, so this was also a one-liner question, and I think most of you got this right. You are asked to prepare the discharge. I mean, this is the last question of a patient who has had a repair for a vesicovaginal fistula. For how long will you ask her to abstain from sexual intercourse, and how long will she delay conception by? So this is probably an obstetric VVF, not one following hysterectomy. Okay, because you've been asked when will she conceive again. Okay, so these were the options given, or roughly these. I'm not sure about the permutations, combinations. Honestly speaking, I've searched Thielens, I've searched Novak's, I've searched Williams Gynae, I've searched Campbell Urology. Okay, and nowhere is it clearly given. In fact, Thielen says it has to be individualized. Getting back to sexual life, everything has to be individualized. But I found this on Google. This is a very recent article. It says, although the literature on the ideal time to resume sexual activity is scarce, intercourse is usually prohibited for a period of 3 to 6 months. However, recent studies have shown that sexual activity can be resumed as early as 6 weeks. So see here, both the things are given. So again, a very doubtful, controversial question. I'm still searching for references. If I get a better answer, okay, so looking at this article, I think 6 weeks would have been a good option. And conception, again, nothing is given. When was her last cesarean? Because if it is an obstetric VVF, it is mostly because of obstructed labor, and for that a cesarean would have been done. When was it done? When was the repair done? Nothing has been given, right? So again, it's sort of a blank, weird question. But if you have comments, please put them on the comment section, and I'll try to get back to you. Okay, I will get back to you. I won't try. I will get back to you. But this is a little So 6 weeks would be the correct answer if we go by this article for abstinence, for resumption of sexual activity. But let me confirm, let me look through more references and then I'll get back to you. Okay. Now, so that ends our discussion. So don't think that the paper went bad or the paper was difficult or tricky. Okay. So even if it is a failure, okay, think of it as a success. Okay. So all of us go through this. All of us have gone through this and we still go through our struggles. This is how life is. So in reality, failure is actually a part of success. Okay, so I wish you all the best for the result. I'm sure you will all do very, very well, and looking forward to good feedback from all of you in the comment section. Thank you so much. You can subscribe to Dr. Me. Please subscribe to Dr. Me. Please subscribe to OBG classes by Dr. Rena. I promise you will find lots and lots of exciting content on these platforms. Thank you.
Dopamine.